renal blood vessel which enormously perfuse the kidney are affected secondarily in majority of renal disease. Renal blood flow is controlled by systemic and local hemodynamic, hormonal and intrinsic intrarenal mechanism. These are the mechanisms. When disease which disturb this controlling mechanism give rise to primary renal vascular lesion. These diseases are as under hypertensive vascular disease, which is most important for you. Then among these, benign and malignant nephrosclerosis, thrombotic microangiopathy, renal cortical necrosis, renal infarcts. Now hypertensive vascular disease. An elevated arterial blood pressure is a major health problem, particularly in developed countries. A persistent and sustained high blood pressure has damaging effect on the heart, brain and kidney. Heart, brain and kidney. These are the three organs where the renal vascular disease affect and hypertensive disease affect. হার্টে কি হয় হাইপারটেনসিভ হার্ট ডিজিজ ব্রেনে সেরিব্রোভাস্কুলার অ্যাক্সিডেন্ট অর স্ট্রোক কিডনিতে কি হয় বিনাইন অ্যান্ড ম্যালিগনেন্ট নেফ্রোস্ক্লেরোসিস Now, hypertension is a common disease in industrialized country and account for 6% death worldwide. Now, epidemiology studies have revealed that with elevation in systolic and diastolic blood pressure above normal in adults, there is a continuous increased risk of cerebrovascular disease, stroke, and renal disease. These are three important diseases. Hypertension is intimately linked with kidney because kidney disease can be both a cause and consequence of increased blood pressure. It is both cause and consequence. Hypertension is generally classified into two types. I will shortly describe the hypertension here. Primary or essential hypertension, here we don't know the cause. And secondary hypertension, here we know the cause. In primary hypertension, we don't know the cause. It is mostly idiopathic. And secondary hypertension, we know the cause. And cause is kidney, endocrine, and some other organ disease. According to the clinical course, both essential and secondary hypertension may be benign or malignant. Benign hypertension is moderate elevation of blood pressure, and malignant hypertension is marked and sudden increase of blood pressure. Now, when blood pressure rises 200 by 140 millimeter of Hg in a previously normotensive person, then we will call it malignant hypertension. And papilledema, retinal hemorrhage, and hypertensive encephalopathy. These are three most important features of malignant hypertension. Among that, papilledema is a very important features. Now, etiologic classification of hypertension. Essential hypertension, genetic factors, racial and environmental factors. Secondary hypertension, renal, among the renal, renovascular, renal parenchymal disease. Endocrine, among endocrine, adrenocortical hyperfunction, hyperparathyroidism, OCP, coarctation of aorta and neurogenic. Now, renal hypertension, our topic of discussion. Hypertension produced by renal disease is called renal hypertension. It can be classified into two groups: renal vascular hypertension in occlusion of a major renal artery, preeclampsia, eclampsia, polyarteritis nodosa, fibrovascular dysplasia of renal artery. And renal parenchymal hypertension. So, renal vascular hypertension and renal parenchymal hypertension. In various types of glomerulonephritis, polynephritis, interstitial nephritis, diabetic nephropathy, amyloidosis, polycystic kidney disease. In either case, renal hypertension can be produced by one of the following three interrelated pathogenic mechanisms. These are very important. First is activation of renin-angiotensin system or RAAS, sodium and water retention and release of vasodepressor material. Full form of RAAS is renin-angiotensin-aldosterone system. This is the schematic diagram of RAAS system. So what is happening here? Decreasing GFR stimulates renin secretion. Renin is secreted from juxtaglomerular cell. Then this renin acts on liver. In liver, angiotensinogen 1. Then from angiotensinogen 1 to angiotensinogen 2. এটা হয় with the help of enzyme named angiotensin converting enzyme ACE. এটা হচ্ছে লাংসে in yes angiotensinogen 2. This is the most potent vasoconstrictor and it acts on adrenal gland. Angiotensin 2 is the most potent naturally occurring vasoconstrictor substance. এটা কি করে না পেরিফেরাল আর্টারিওলার vasoconstriction করে। তো vasoconstriction করলে blood pressure will rise, increase. And it has another mechanism. The other main effect, reabsorption of sodium and water. Then sodium and water retention, first, second is, it itself is a potent, very potent vasoconstrictor. Now, effects of hypertension. Hypertension is hollow. Now, effect. What will be the effect? Systemic hypertension causes major effects in three main organs: heart and its blood vessels, nervous system, and kidney. The renal effects in the form of benign and malignant nephrosclerosis. Now, benign nephrosclerosis. Nephrosclerosis is the term used for the renal pathology associated with sclerosis of renal arterioles and small arteries. It is strongly associated with hypertension, which can be both a cause and consequence of nephrosclerosis. Clinical features কি হবে? Headache, dizziness, palpitation, and nervousness. Renal function test and urine examination are normal in early stage. In long-standing case, there may be mild proteinuria with some ironing or granular cast. Rarely renal failure and uremia may occur. Now, morphology. This is important for your pathological aspect. Morphology, first grossly, then microscopically. Grossly, both the kidneys are affected equally and they are reduced in size and weight. Kidney will be small kidney will be contracted. Often weighing about 100 gram or less, it will be finely granular and shows V-shaped areas of scarring. The cut surface shows firm kidney and narrowed cortex. কিন্তু মনে রাখবে এখানে যে kidney will be small. Kidney will be small and contracted. Now here we can discuss some other cause of small contracted kidney. Chronic glomerulonephritis, chronic pyelonephritis, benign nephrosclerosis, amyloidosis of the kidney, myeloma of kidney, diabetic nephropathy. Here are the other cause of small contracted kidney apart from benign nephrosclerosis. This is the picture. Small contracted kidney, and these are the scar mark. Now microscopical. Microscopically, there are primarily diffuse vascular changes which produce parenchymal changes. First is vascular changes. Vascular changes in blood vessel involve arterioles and arteries up to the size of arcuate arteries. Hyaline arteriosclerosis, intimal thickening due to proliferation of smooth muscle cells in the intima, and parenchymal changes. So, hyaline arteriosclerosis, intimal thickening, and parenchymal changes. Glomerular shrinkage, deposition of collagen in Bowman space, periglomerular fibrosis, tubular atrophy, fine interstitial fibrosis. Please remember these features, okay? দেখতে পাচ্ছ সবাই? আমার মনে হয় না কিছু দেখতে পাচ্ছি না। This is the sclerosed glomeruli, okay? And this is the hyalinized blood vessels, hyaline arteriosclerosis. Now malignant nephrosclerosis. In malignant nephrosclerosis, clinical features, blood pressure, again বললাম, it will rise up to 200, more than 200 by 140 mm of Hg. Headache হবে, dizziness হবে, impaired vision, এগুলো হবে। আর the presence of papilledema, যেটা আগেও আমি বললাম, presence of papilledema distinguish malignant from benign nephrosclerosis, benign hypertension. Urine frequently shows microscopic hematuria and proteinuria. Then blood urea nitrogen will be high and serum creatinine will raise. Approximately 90% of patients die within 1 year from causes such as uremia, congestive heart failure, and cerebrovascular accident. So, malignant hypertension is dangerous. Now, morphology, gross and microscopical. Gross, in a case of malignant hypertension, superimposed on pre-existing benign nephrosclerosis, kidney will be small in size. যদি সুপারিম্পোজ করে benign নেফ্রোস্ক্লেরোসিসের উপরে, তাহলে it will be small contracted kidney like benign nephrosclerosis. But যদি এটা পিওর ফর্মে হয়, পিওর ফর্ম অফ ম্যালিগনেন্ট নেফ্রোস্ক্লেরোসিস যদি হয়, তাহলে it will enlarge, তাহলে কিন্তু স্মল হবে না। Kidney of the patient develop malignant hypertension in pure form, it will enlarge, edematous, and have petechial hemorrhage on the surface, producing so-called flea-bitten kidney. যেটাকে বলা হয় flea-bitten kidney. Now microscopical vascular change, These are more severe and involve arterioles. The two characteristic vascular change, necrotizing arteriolitis, hyperplastic intimal sclerosis, or onion skin proliferation, and ischemic changes. Ischemic changes, the effects of vascular narrowing on the parenchyma include tubular loss, fine interstitial fibrosis, and foci of infarction necrosis. So, vascular necrotizing arteriolitis, hyperplastic intimal sclerosis, or onion skin proliferation, and ischemic changes. এই যে ফ্লি বিকেন অ্যাপিয়ারেন্সটা হয় এটা হচ্ছে ডিউ টু হেমারেজ, পেটেকিয়াল হেমারেজ। দিস আর দ্য পেটেকিয়াল হেমারেজ। This is the malignant nephrosclerosis microscopical picture. এগুলো হচ্ছে অনিয়ন স্কিন proliferation, আর এটা হচ্ছে ফাইব্রিনয়েড নেক্রোসিস, এটা হচ্ছে ফাইন ইন্টারস্টিশিয়াল ফাইব্রোসিস। Now, thrombotic microangiopathy. The term thrombotic microangiopathy encompasses the spectrum of TTP, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome, HUS and TTP. এই দুটো ডিজিজ নিয়ে হচ্ছে thrombotic microangiopathy. HUS and TTP are caused by thrombi in papillary and or arterioles in various tissue bed. Thrombotic microangiopathy কি থাকে? মাইক্রোভাস্কুলার থ্রম্বোসিস, মাইক্রোঅ্যাঞ্জিওপ্যাথিক hemolytic anemia, thrombocytopenia, TTP, and hemolytic uremic syndrome or HUS. These are the components. Now cause. Infections like E. coli, Shigella, Pseudomonas, drugs, mitomycin, cisplatin, autoimmune disease, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, pregnancy and preeclampsia, malignant hypertension. Now clinical features. Microangiopathic hemolytic anemia, thrombocytopenia, DIC, and eventually renal failure. This group of disorder is classified according to the current understanding of their cause. Typical HUS দু রকমের হয়, typical HUS আর atypical HUS. Typical HUS কে বলা হয় diarrhea positive or classic HUS. Is most frequently associated with consumption of food contaminated by bacteria producing Shiga-like toxin. Shiga-like toxin produce typical HUS. Atypical HUS, diarrhea negative, is associated with endothelial injury, including antiphospholipid antibody, complications of pregnancy and OCP, vascular renal disease such as scleroderma and malignant hypertension, chemotherapeutic and immunosuppressive drug and radiation. Now TTP. TTP is characterized by inherited or acquired deficiency of ADAM-TS13, a plasma metalloproteinase that regulates the function of von Willebrand factor. Actually, ADAM-TS13 কি করে না, von Willebrand factor একটা লার্জ মাল্টিমার ওটাকেও ক্লিপ করে। von Willebrand factor is clipped by ADAM-TS13. So if AGAM-TS13 is absent, then von Willebrand factor will not be cleaved হবে না। তার ফলে ওটা একটা লার্জ মাল্টিমার হবে এবং তার ফলে প্লেটলেট কোয়াগুলেশন হবে, প্লেটলেট মাইক্রোথ্রম্বাই হবে। TTP is characterized by formation of hyaline microthrombi in microcirculation of various organs due to aggregation of platelet. In idiopathic TTP, autoantibody against AGAM-TS13 lead to deficiency of AGAM-TS13 and accumulation of ultra-large von Willebrand factor multimer that bind large number of platelet. এই কারণের জন্যই প্লেটলেট মাইক্রোথ্রম্বাইটা হয়। Now pathogenesis. Endothelial injury number 1. In typical HUS, the trigger for endothelial injury and activation is usually a Shiga-like toxin. While for inherited forms of atypical HUS, the cause of endothelial injury appears to be excessive, inappropriate activation of complement. The endothelial injury in HUS appears to cause platelet activation and thrombosis within microvascular bed. The two important features of TTP, platelet activation and thrombosis. There is evidence that reduced endothelial production of PGI2 or prostaglandin I2 and nitric oxide, both inhibitors of platelet aggregation, contribute to thrombosis. Now second is platelet aggregation. In contrast to HUS, in TTP, the initiating event appears to be platelet aggregation induced by very large multimers of von Willebrand factor. কেন হয় very large multimer of von Willebrand factor বললাম আমি, which accumulate due to deficiency of AGAM-TS13. AGAM-TS13 deficiencyর জন্য large multimer of von Willebrand factor হয়। That cleaves von Willebrand factor multimer is into smaller size. The deficiency of AGAM-TS13 is most often caused by autoantibody that inhibit AGAM-TS13. Very large von Willebrand factor multimer can bind platelet surface glycoprotein and activate platelets spontaneously, providing pathophysiologic explanation for the microthrombi that observed in vascular bed. Now the pattern of manifestation of TTP. There are 5 features of TTP. First is microangiopathic hemolytic anemia, MAHA. কি হয় না, hemolysis of red cell, peripheral blood clear আমরা কি পাবো, fragmented red cells, NRBC and reticulocyte count will be increased. Increased LDH and unconjugated bilirubin in serum indicate increased hemolysis. Bleeding manifestations secondary to severe thrombocytopenia such as petechiae, ecchymosis and epistaxis. Fluctuating neurologic dysfunction, renal abnormality, proteinuria, hematuria, azotemia and fever. So there are 5 features of TTP. First is microangiopathic hemolytic anemia. Second is bleeding manifestation. Third is fluctuating neurologic dysfunction. Fourth is renal abnormality, and fifth, fever. For unknown reason, in TTP, central nervous system involvement is the dominant feature. So among these, central nervous system involvement is the main features. Whereas renal involvement is seen in about 50% patient. The clinical findings are dictated by distribution of the microthrombi which found in arterioles throughout the body. So main features is microthrombi in renal vascular bed. With plasma exchange, which remove autoantibody and provide functional RMTS 13, TTP can be treated successfully in more than 80% of patients. So treatment is plasma exchange. Now morphology, fibrinoid necrosis, thrombi in renal microvasculature, the most important one, edema of intima of arterioles, and consolidation, necrosis, congestion of glomeruli. These are the fibrin stain showing thrombi. These are the thrombosis in red color. Now, other vascular disorder, one is sickle cell nephropathy. Sickle cell disease or trait may lead to a variety of alterations in renal morphology, and some which produce clinically significant abnormality. The various manifestations are grouped under sickle cell nephropathy. The most common abnormality, hematuria and diminished concentrated ability, যেটাকে বলা হয় hyposthenuria, patchy papillary necrosis and cortical scarring and proteinuria. Now, renal cortical necrosis. Renal cortical necrosis is infarction of renal cortex, varying for microscopic foci of a situation where most of the renal cortex is destroyed. The megala, the gastromegalory cortex and rim of cortex and the capsule are usually spared. The condition develops most commonly as an obstetrical emergency in a form of eclampsia or preeclampsia. The lesions may be focal, patchy, or diffuse. The gross and microscopic characteristics of infarcts of cortex are present. Patient PA present করবে sudden oliguria or anuria and hematuria. This is the cortical, diffuse cortical necrosis. Now, the summary. Take home message. Hypertension may be primary or essential hypertension in which the cause is unknown, or secondary, যেটার cause আমরা জানি, kidney, endocrine or some other organs. Clinically, hypertension may be benign. Benign কখন বলা হবে 90/140 ওপরে হলে। আর malignant hypertension যখন pressure will be more than 200/140. Main mechanism of essential hypertension are activation of renin-angiotensin-aldosterone pathway. While secondary hypertension may be due to endocrine, aortic coarctation or neurogenic causes. Systemic hypertension cause major effects in three main organs: heart and its blood vessels, nervous system, and kidney. Then thrombotic microangiopathy encompasses a diverse set of conditions, deposition of thrombi in the microvasculature, accompanied by red cell hemolysis, tissue ischemia, and organ dysfunction, and consumptive thrombocytopenia. In typical HUS, Shiga-like toxin, most commonly E. coli, strain is 0157H7, is responsible for producing platelet activation and thrombosis. In most cases of atypical HUS, aberration activation of complement due to inherited mutation or acquired autoantibody is the key pathogenic abnormality. In TTP, deficiency of ADAM-TS13, a negative regulator of Von-Willebrand factor, permits the formation of abnormally large multimolar Von-Willebrand factor that are capable of activating platelet. And these are the two important features for your point of view. One is TTP and benign nephrosclerosis and malignant nephrosclerosis. But there are some other renal vascular disease like sickle cell nephropathy, renal cortical nephrosis, and infarcts. There are some other renal vascular diseases.